Hello guys, good evening. How are you doing? I am Dr. Amrit Nasta, a bariatric surgeon from Mumbai, and today I have curated a very special, interesting topic, and that is image-based questions from Bailey and Love. So just give me a few seconds, let people join in, and then I will begin today's class. I have put a lot of interesting images. Now, mind you, we all have realized how important Bailey and Love has become. Not just in NEET PG but even in mid-year exams. So we noticed that there were a lot of direct questions even in the AIMS exam that was conducted a few weeks back, directly from Bailey and Love. And obviously, NEET PG will primarily be based on this. So what my subsequent classes as well as my courses will be focused on this book so that all of you who are interns who don't have time to read, obviously you can't read Bailey and Love now, at least your life will become a little easier by attending my classes. While we wait for people to join in, yes, good evening Rishikesh. So while we wait for people to join in, let me just tell you a little bit about myself and what we offer at Unacademy. So I am Dr. Amrit Nasta. This is my referral code DRAMRIT-YT. I conduct special classes every Friday as well as YouTube classes. You can follow me on my profile on the Unacademy Neetpg Live YouTube channel. You can use my referral code. This is how you can subscribe to the Plus platform. There are a lot of subscriptions depending on what duration you are looking for. Good evening, Avinandan Mishra. These are some of the daily YouTube classes conducted by the different educators. Currently, all these classes are going on, and these are the free classes or the special classes as they are called on the Unacademy app. So as you can see, daily there are a lot of classes happening. A foundation batch course has just started. So if you are looking for NEET PG 2021, this is the course you should definitely enroll for on the Plus platform. And that's all we have to offer. These are all going to be live classes. It's not just going to be me. There will be a lot of educators covering all the subjects. So without spending more time, let's begin. This is going to be an MCQ based class. Let me tell you, everything I have put today image based is from Bailey. It's not the exact image obviously for copyright reasons, but I have based the images from exact topics. And let me tell you, I just took two chapters from Bailey. Good evening Karthik, good evening Swati, good evening Suresh. I just took two chapters from Bailey. It took me not even 5 minutes to come up with all of these images, and I could have come up with hundreds of questions from the different just two chapters of Bailey and Love. So understand the wealth of information that is there. Alright, so it is my job to make your life in surgery easy, targeting NEET 2021, targeting good coverage of Bailey and Love. So you'll notice a lot of my classes as well as my courses on Plus will be based on Bailey and Love. Alright, so try to interact. I can see your messages on my phone in the chat box. So let me see, and you will realize there are a lot of images which you may have seen if you have read Bailey, and some images which you would have not even imagined that they could be there in Bailey. I have taken them just from two chapters. Okay, just two chapters. So just imagine how much I could come up with and how much they can come up with in your papers. Alright, so let's begin with the first MCQ. Let's see if you have seen this image. Is it possible only to subscribe only surgery? No, I am afraid not. Okay, so if you have seen this image, as simple as it looks, tell me the use of this device. This has never been asked. It's there in Bailey and Love. This device is used in men with urethral stricture, women with recurrent UTI, incontinence in pediatric population, both A and B. Good evening to all of you. Good to see so many of you online. This is a Bailey and Love based image question. First, identify what this funny looking device is. This is there in Bailey. Everything today is from Bailey. And what is it used in? Yes, some of you are saying A, some are saying C. Come on, guys. Is it C? Is it A? Is it both A and B? Great. I'm seeing all answers coming now. Some A, some C, some D. Great. Anyone for B? Good, 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 good. Okay. So first of all, yeah, some of you are right. Quite a few of you are wrong also. First of all, let us identify this. So this, one person gave the correct answer. This is a Euroflowmeter. This is a Euroflowmeter. It measures urine flow rate. It measures the urine flow rate. But so basically, Euroflowmeter or urine flow rates are measured in both men with urethral stricture and women with UTI. However, this particular Euroflowmeter is used only in men. Obviously, this cannot be used in women. This is used only in men. So the answer is men with suspected urethral stricture. I don't think you would have imagined a question like this, but open Bailey and Love, it's there. And these points also are taken from Bailey and Love. So this is used in men with suspected urethral stricture or in men with bladder outlet obstruction. In women, you use a different Euroflowmeter. I'll show you what it looks like. This is the one that is used in women. Obviously, you need a commode type of Euroflowmeter. Now, how is it used? You sit on the pod, you pass urine, it's timed and measured, it is connected to a computer. So it times and measures your urine flow rate. How much urine are you voiding per second? Again, wealth of MCQs. Normal urine flow rate is more than 15 ml per second. If it is less than 10 ml per second, you have significant bladder outlet obstruction. Okay, you have significant bladder outlet obstruction. That is the use of measuring your urine flow rate. After the urine flow rate is measured normally, you also measure the amount of residual urine, which is done by ultrasound. So how much urine is left behind after you have voided? Because people with bladder outlet obstruction, they have incomplete evacuation. So this can be quantified. Now there is a different test which is called urodynamic study. Don't confuse urodynamic study with urine flow rate. Urine flow rate is a simple test. You just calculate how much urine you are passing per second. Urodynamic study is a pressure measurement study. Okay, so a catheter is passed with pressure probe into the bladder. The bladder is filled and pressures are measured while it is being filled and during voiding. And different conditions of the bladder can be measured or diagnosed. Neurogenic bladder, hypertonic bladder, detrusor hyperactivity, all kinds of bladder motility problems can be diagnosed. So detrusor hyperactivity and so on. Okay, so urodynamic study is something different. A catheter probe has to be passed, the bladder has to be filled, pressures are measured, then while you are voiding the pressures are measured and you get a urodynamic performance rate. Okay, so don't mix the two. Even this image is there in Bailey and Love, by the way. This is also not my own, this is also there in Bailey and Love. Alright, so that was the first one. So now you got the idea of the first chapter that I've taken. Let's see if you can solve this one. This again, direct image from Bailey. You can open Bailey, one of the chapters of urology, one of the earlier chapters, the investigation ones or the kidney one has this. So which procedure gives you a complication that you are seeing marked? What is this complication? And what procedure gives this complication? This image, very important. I had myself not seen it. Trust me. I had myself not seen it. So what procedure gives you this complication? Great. Excellent. A lot of you have given the correct answer. Great. So what you are seeing are multiple radioopicities along the ureter. So this, as you are correctly saying, is called Steinstrass. Steinstrass, not Senestrass, Steinstrass. Stein is a German lingo. Anything that is EIN is of German origin. And this is seen after ESWL. So all of you got it correct. Anybody can tell me what is Magenstrass or Machenstrass? Anybody knows what is Machenstrass? Like you have Steinstrass, you also have Machenstrass. Where do you see Machenstrass? The G is pronounced like an H in the language. It's not Magen, it's Machen. Where do you see this? Anybody? Machenstrass? See, it's not that I will always ask you what you know. No, nobody? Kishore, Ritesh, Sushmita, so many of you, 46 of you are online. Nobody knows the answer of Machenstrass. Okay, it is seen in stomach, no. It is seen in retroperitoneal hemorrhage. It's seen in retroperitoneal hemorrhage, Machenstrass. Anyways, so about ESWL, important things. It is one of the treatment of stones, renal stones. The size should be less than 1.5 centimeter. All these points are from Bailey and Love. Non-lower calycial stone. Understand, ESWL cannot be used for stones in the lower calyx because lower calycial stones will not get drained. Okay, so non-lower pole calycial stones, yes, Steinstrass means street of stone, so it looks like a street of stone. Cystine stones, they are relatively resistant to ESWL. Most common complication is infection, which is why you must give antibiotics and hemorrhage, of course. And these are the contraindications: coagulopathy, pregnancy to ESWL. I have always told you in my class, if there is any complicated scenario of stones, the answer will always be PCNL. Okay, any complicated stone scenario, obese patient, bleeding tendencies, big stone, wrong stone, stone stuck somewhere, previous surgery, previous radiation, PCNL will be the answer. Okay, pain is not a complication. Yes, complication is infection, and that's because the stones are formed over infected nidus. So the nidus is a bacteria, so they are formed over an infected nidus. So when the stone breaks, the bacteria can be released. That is why infection is common. Alright, so that was about ESWL. Let's see if you can solve this. One more urology question. So you know my first three questions are from urology. Well, just one chapter from Bailey and Love gave me all of these. Identify the incorrect statement about the procedure. So this is a procedure in different steps. There is a similar image in Bailey and Love where the procedure is given in 5 steps. Obviously, I could not copy it, so I have taken an image from the internet. What is the incorrect statement about this procedure? The image of the procedure is there. Involves resection of pelvis. Overlying renal vein is divided if it is present. Also known as endopylolysis. Can be performed by a robotic approach. What is this procedure that is done? You can see there is some problem over here, then something is done over here, then some suturing is done. Okay, most of you are saying B, just following the leader, and overlying renal vein if is divided if present. Okay, yes, the procedure is correct. This is Heinz's dismembered pyeloplasty. That is correct, Srinivas. This is a dismembered pyeloplasty. Can you tell me what it is done for? Dismembered pyeloplasty. What is the pathology for which it is done? Most of you have said B, someone has said A, someone has said C. No one for D. Can be performed by robotic. Ever heard of dismembered pyeloplasty being performed robotically? What is the indication for dismembered pyeloplasty? It's for congenital PUJ obstruction, pelviureteric junction obstruction, congenital PUJ. So yes, you are correct. This is a dismembered pyeloplasty. Don't call it hydronephrosis, Monica. Hydronephrosis has millions of causes. One of the causes, a common cause, is a PUJ obstruction, as you are seeing over here, for which you do dismembered pyeloplasty. Now, dismembered means obviously you are going to dismember or separate. That means resect. So you are going to resect. So this part where the stricture is or the obstruction is going to be resected. The pelvis is going to be resected, which has become dilated. So this is correct. An overlying renal vein is divided if present. Now a lot of times the narrowing is because of a compressing vein on top. It's not always a stricture, congenital stricture. A lot of times the narrowing is because there is a vein on top which is compressing it from outside. If the vein is compressing it from outside, then you can divide it. So most of you got this wrong. Overlying renal vein can be divided. Direct statement from Bailey and Love. Open it and see. Endopylolysis is not the other name. This is not endoscopic. Endopylolysis is something totally different. So the correct answer is also known as endoscopic pylolysis. Very few of you got this correct. Can be performed by robotic, yes, can also be performed by laparoscopic approach. If you see this picture, these instruments, these are laparoscopic instruments. This is not open pyeloplasty. Originally described in open surgery, nowadays done laparoscopically or robotically. Can be performed. Okay. Each and every line is from Bailey and Love. Endoscopic pylolysis is something very different. So about hydronephrosis, one of the causes is PUJ obstruction. This is the typical IVU appearance where you get a clubbed pelvic glycal system, dilated pelvic glycal system with clubbing. Yes, both लोगों ने गड़बड़ कर दिया. So you get a clubbed pelvic glycal system. There are a lot of surgeries described. The commonly used one is the Heinz's dismembered pyeloplasty. There is also a Foley's plasty. It's called Foley's YV plasty. A Culp's procedure and endopylolysis. Endopylolysis is basically you do a ureterorhinoscopy and you can do a balloon dilatation. One of the ways of dilating it is with balloon, that is done endoscopically. That is endoscopic pylolysis. Okay, something quite new done by endourologists. And remember, in hydronephrosis, you will perform nephrectomy only if the function is less than 10%. If the renal function of that affected kidney is more than 10%, MCQ, do not remove the kidney. Even 10% is enough. Okay, even 10% function is enough. Alright, I could have come up with 30 questions like this from just urology. So please guys, I know you won't get time to read Bailey and Love, but please at least attend my questions, my classes which are based on Bailey and Love. A lot of them will be. Alright, very common instrument, again picked from one of the chapters. Identify this instrument. Is it a Barron's band applicator? Barron's band applicator used in hemorrhoids. Is it a rigid sigmoidoscope, flexible sigmoidoscope, or a hernia dissecting balloon? Okay, again directly picked from Bailey, this image. Not the same, obviously, but inspired. I cannot pick the ditto image. So what is this device? Is it a band applicator for hemorrhoids, sigmoidoscope rigid, flexible, or a hernia balloon? Let's see what you think about it. Interesting, yes. Shini was saying length 60 centimeters. When you say more, you know less. Never overcome it. Okay. Yes, most of you have gotten the correct answer. This is a rigid sigmoidoscope. Absolutely correct. This is a rigid sigmoidoscope. So rigid sigmoidoscope, this is the main scope. This is the obturator which is passed inside the sheath. Okay. This is just some instrument to grasp like a biopsy instrument. What is more important and diagnostic is this. Anybody can tell me what this is? What is this device? Yes, Star got it wrong. Premnath also got it wrong. Sushmita also wrong. It's rigid sigmoidoscope. What is this thing over here at the top? And this is what will help you diagnose the rigid sigmoidoscope. Excellent. This is an insufflator. This is an insufflator. Whenever we are doing endoscopy, any endoscopy, whichever lumen we enter into, we have to dilate the lumen. Only then the scope will be passing and you will get a good vision. When we do flexible scopies, in flexible endoscopes, the machine blows the air. So the flexible endoscope is connected to a machine and the machine blows the air. This rigid device does not have any machine. So I have to manually insufflate it. So this tube is connected to one of the channels, and when I've introduced it, I insufflate it. So when I insufflate it, the rectum, the sigmoid will distend, and then I can see. All endoscopies in GI or hollow organs require some form of insufflation. Even when you do cystoscopy, you insufflate it, but there you don't use air, there you use some liquid medium, because in the bladder you need liquid medium, not air. But in GI you use air insufflation. So this is the insufflator, manual insufflator for rigid sigmoidoscope. This is your flexible sigmoidoscope. Looks the same like a gastroscope or a colonoscope. They all look the same. All the flexible scopes look the same. The difference is only in length and the diameter. Length and diameter is what is different. So all these are important MCQs, everything from B. A proctoscope is of length 10 to 15 centimeters. Remember, proctoscope does not see the rectum, it sees the anus. Little bit of rectum. It will not see the full rectum. The correct name should be anoscope. It should not be proctoscope. It should be anoscope. It is a more appropriate term. Rigid sigmoidoscope is 25 centimeters. Someone answered 60 centimeters. 60 is for flexible. And colonoscope is 160. Anybody can tell me length of gastroscope? Flexible? Flexible gastroscope length? Anybody? Yes, and by the way, this that you see, this is the band ligator used in hemorrhoids. So this is where you apply the band. With this you grasp the hemorrhoid, so they both go together. With this device you grasp the hemorrhoid. With this device you deploy the band, and the band will go onto the neck of the hemorrhoid and cause strangulation. Yes, gastroscope flexible is 100 to 120 centimeters. Okay, so it's like 30, 60, 120, 160, something like that. Alright, so that is the Barron's band ligator and the different endoscopes. Let's see if you can identify this one. This again is from Bailey and Love. Not the same image, or different image. I could not find a more representative image than this, but definitely it's new. Okay, not yet been asked. What is the role of this device? Stapled hemorrhoidopexy, WAF, TATME, or Delorme's? It's quite new. What is the role of this device? I hope you know the full forms of all of these. Okay, great. Everybody is giving a different answer. ABC, all have been marked by you. Important question. I would be very worried with a question like this. Okay, I got all stapled WAF. What is WAF? What does WAF stand for? Anybody? Most of you are saying hemorrhoidopexy. What is waft? Yes, Akanksha, what is waft? Sphincter saving procedure. What does it stand for? What does waft stand for? Sphincter saving procedure of what? Okay, most of you are saying stapled hemorrhoidopexy. Does this look like a stapler? I don't think so. It does not look like a stapler at all. It's not a stapled hemorrhoidopexy. WAF is video assisted anal fistula tract ligation or tract surgery. Obviously, I am not doing any fistula surgery here. What I am doing, I am going over here. Can you see where I am going? There is a marking over here where it's gone. What is this place called? So this is the rectum. This is the sacrum. The part behind it is your mesorectum. My God, I am getting even D has been marked now. Sauji and Anu have marked D also. No, it's not D. Answer is TATME. Transanal total mesorectal excision. Very new procedure. It is a procedure for early rectal cancers. Early rectal cancers. T1, sometimes early T2 also, which are lower down. You do a endoscopic mesorectal excision with excision of the tumor. So this is like a specialized device. There is a camera and there are instruments with which you will excise the tumor, excise the mesorectum as much as possible and close the defect. Everything done transanally. So you don't have to do an AR or an APR. You are simply doing a transanal excision that is called TATME. There is a very nice image of this in Billion Love. Please have a look at it. This is not the same one, but this is the closest I could get online. Okay, must know TATME. This is stapled hemorrhoidopexy, which all of you answered. A stapler looks like this. This is the anvil of the stapler. This is the anvil. This is the stapler. The file mass is taken in between and the file mass is fired. This is stapled hemorrhoidopexy. Again, it's there in Bailey and Love. This is Delorme's procedure. Delorme's procedure, which is done for rectal prolapse. Delorme's procedure, which is done for rectal prolapse, where what you do is you excise the prolapse mucosa and then you take plicating sutures on the muscularis. You take longitudinal plicating sutures on the muscularis, and when you plicate it, the prolapse shrinks. That is Delorme's procedure. Again, this image is there in Bailey and Love. So I've given you a lot of information today just to re-emphasize the importance of these kind of things, which will probably be asked in your exam. Alright, so this is about Delorme's procedure. This is stapled hemorrhoidopexy. VAFT WAFT, they will not ask you. There is no image of that in the books also. Alright. This again, direct image, ditto image. I will make your life a little easy. I have put the name of the procedure for the disease. This is the procedure done for pilonidal sinus. I will also describe it for you. Incision is taken here. This is the pilonidal sinus. Incision is taken here. I have debrided everything from the lateral side and I have excised things over here. What is this procedure? Okay, great. A, C and D. Anyone for B? Mind you, all of these are done in pilonidal sinus. Okay. So don't say only Limburg is done or only Bascom. All of them are done and all of them are represented by images in Bailey. So pick one of them. What is this procedure? Where I don't excise directly, I take a lateral incision. Then go in the pilonidal sinus cavity, excise it and excise the tracts. Awesome. A, B, C, D. All answers are given. Nobody went for Caryodacus. This is there, by the way. Caryodacus. It's not my creation. Great. If I were you, I would have definitely not marked Z plasty, because Z plasty, there is nothing Z shaped in this. In Z plasty, you create two flaps and then you transpose them. That is Z plasty. Definitely, this is not Z plasty. I would have thought between A, B, and C. Some of you got this correct. Answer is Bascom's procedure. Okay. In Bailey, there are 3 images of Bascom. One step after another, 3 images. So what is done? You don't incise directly on the tract. You incise laterally. Go inside the tract. Remove all the debris. Remove all the hairs. And just excise a little bit of this, the sinuses, not the whole thing, and close this. This part is closed. The lateral incision is left open. Okay, just the lateral incision is left open to drain the tract. That is Bascom. So for Bascom, it's a lateral incision. Anybody can tell me what is 1A and 1B? This is the same procedure, 1A and 1B. What is this? So this is my pilonidal sinuses. I have taken an elliptical incision, but which is a little more lateralizing. So it's an elliptical incision, but it's away. This is the sinus. It's not centering on the sinus. It's going away. It's eccentric. It's eccentric. So this is Cariadakis. This one, where I take an eccentric incision, excise everything and suture it. So when I suture it, the suture line comes laterally. That is the importance of this incision. It's an incision like this. It's like a D incision. So when I suture it, the suture line comes lateral. That is the advantage. I don't want my suture line to come in midline, because then the recurrence will be higher. And this, I hope all of you know this one. I excise it like this. I take a flap from the side, I rotate it, and I suture it like this. I hope everybody knows this one. This I have also taught earlier. This is the conventional Limburg flap. I have taught this flap in all of my previous classes. Limburg flap, also a type of rhomboid flap for pilonidal sinus. Alright, so you got to learn a lot of things which probably you knew but definitely never focused on. So what I want to do in my upcoming courses on the Plus platform is focus only on Bailey and Love. So I have already published a course on general surgery which is going to start this Sunday. Okay, and it is based on chapters and patterns of Bailey and Love, like basic principles. So you open the textbook, you will see the same topics: basic principles, diagnosis, perioperative care, trauma. After that, I'll do GIHPB and then I'll do super specialty. In the next 3 to 4 months, my plan is to comprehensively cover this textbook, line by line, as much as possible. Okay, so these are my upcoming courses. If you wish to join me on the Plus platform to learn surgery, this is what is lined up. Definitely it will have image based questions, clinical questions, and one-liners, covering as much as possible, because I know for a fact you don't have the time to go through it in internship. And now it's only about 5 to 6 months left. You cannot go behind reading Bailey and Love. It's not that time is gone. So you leave it to me and let me try to make your life easy. Do remember to follow me on my profile on Unacademy. Give a thumbs up at the end of the class in the review section. Can you subscribe only for surgery? I am afraid not. Sir, I am FFNG. I lack very much knowledge compared to Indian, but your classes are really great. Thank you, Ritesh. So keep coming for my classes. No, you can't subscribe only for surgery. You have to subscribe for everything, but the subscriptions are not so much. So you can join me for my classes. There are a lot of educators. All subjects will be covered. So that's where I stop here today. Thank you guys for joining me. Please give a thumbs up at the end.